Hi everyone, my name is Deba and welcome to my channel. I am a registered dietitian in South Africa and I decided to create an educational channel mainly to give tips and tricks to dietetics students and also to help understand and to explain how to do the different aspects that's required of you to complete during the degree. So specifically for this video, I'm going to be covering how to do an integration, specifically for your NCR, so your nutrition care record. Um, so yeah, let's get into it. It's an integration basically is something that a lot of us struggled with during our undergrad studies. Um, there's many ways of doing it, but this I'm going to be showing you how I learned how to do it and how I ended up doing it. And it was only towards the end of my clinical block that I actually learned how to do it in a very easy way. So let's get into it. Okay, so the case study that I'm presenting is a hypothetical situation. I try not to make it too complicated or, just so that we understand how to get into the integration. Okay, so we have a background. So we have the patient background here. 52-year-old male who is unemployed with a low socioeconomic status background. He has hypertension and he was diagnosed with it in 2018. He is on enalapril and Mlock. He's a smoker with a 10-year back history, consumes alcohol often, and he was admitted with renal dysfunction. They said acute and chronic kidney disease, and they also said that he has iron deficiency anemia. Okay, so looking at our ABCD, so our assessment, anthro, the BMI was 30, so we classified him as class 1 obese. And then he also had central adiposity. And then if we look at the arm muscle area and arm fat area, so the muscle stores was quite low because he was less than the 5th centile. He had excess fat stores, which was the arm fat area was above the 50th centile. Okay, then if we look at the biochem, the UNE specifically, so urea and electrolytes, the sodium was low, potassium and phosphate were high. It's typical in, AKIs or CKDs to have a high potassium and phosphate values because of the kidney dysfunction. And then as well as a markedly high urea and creatinine, which then indicates, uremia or uremic syndrome. But there was no uremic frost present. So yeah, we could say uremia. And then he had low calcium, the GFR of 16, so not quite stage 5 as yet. He had a high CRP and a low albumin of 28. And he had low RBC count, the hemoglobin, iron and ferritin stores were low. So that indicates the iron deficiency and anemia. If you look at the clinicals, so the blood pressure was 147 over 90. Yes, it's elevated, but he does have blood pressure. His HGT were normal. The other vitals were also normal. Fluid output was, the fluid input was 650 moles. Urine output was 300 moles. So this indicates he is oliguric. Okay. And then he didn't have any nausea, vomiting, diarrhea. So from this, we do note that he does have a positive fluid balance. Obviously, in the hospital, you need to see a trend that will help you establish if he's been accumulating fluids every day and that sort of thing to look for a trend. But this is purely hypothetical, so that's why I made it really simple. Okay, if you look at your nutrition-focused physical exam, so with the nails, we found that he had a poor capillary refill. You might also have found that he might have a bile conjunctiva as well. He was slightly irritable. He had bipedal edema, right? And then there was no IV. There was there was meds. So he was on Titrelac, Kayexalate, and Claxane, and he was awaiting a blood transfusion. Okay, looking at the diet history that we got from him, his diet was high in salt, sugar, refined carb intake, high alcohol intake. He had an inadequate fiber intake, and he also had a high processed meat intake. Okay, and then in hospital, he reports that he only consumes 70 to 80% of all food from meals, but he reports some anorexia. Okay, so the anorexia could also be related to the urea and the accumulation of toxic products inside the body. Okay, so this is a basic outline of how the integration ideally should be, but this is what I work on. So everybody has their different ways of doing an integration. I follow this, I want to say, this blueprint, so to say. It's easy if you have an outline in your head or on paper or something on how you want it to look or how ideally it should be, just so that it flows better and it makes sense. Okay, so starting from the top. So this can be used, I mean, now we're doing an internal medicine case, but it can be used for surgeries. With surgery, it becomes a bit more complicated because they go for multiple relooks and things like that in procedures, etc. Also with pediatrics, it might also be complicated because conditions change rapidly in peds. But specifically, I mean, this is just the basic outlay that I use. So at the top, we have the possible causes for the disease conditions, example, genetics, lifestyle, and habits. So this is what will cause your disease condition. Okay, say now our patient, well, in our case, our patient has an existing condition of hypertension. Okay, so then it's going to go in the second box. So all of these causes of disease, such as genetics, lifestyle habits, all of that, environmental factors, for example, pollution, things like that, they all contribute towards the disease formation. So in this case, like his alcohol use or smoking habits then causes the hypertension. Okay, in his case. So the other disease conditions is going to be the hypertension. And then obviously these disease, the pre-existing disease conditions will contribute towards the disease condition that he is admitted with. In some cases, it might not contribute towards the disease that they have been admitted with. In other cases, it would. For example, a hypertensive patient comes in with a gunshot wound, injury or something like that. There, in that case, the hypertension, we can't say the hypertension had led to the gunshot wound injury. Okay, so that doesn't, that doesn't make sense. But in our case, in internal med, some of the conditions are linked. So, yeah. Okay, so your disease condition that the patient was admitted with, and then I find this, during my third and fourth year, and then only towards the end of the clinical block in my fourth year, did I include the pathophysiology, which is important to include. It understands you, and helps you understand the disease better. It helps you understand where nutrition comes in. It helps you understand everything clearer and links everything nicely, I want to say. So this is important. Wherever possible, please try and include the pathophysiology. I mean, it might not be part of your best statements. It might be part of your best statements, but it's important. Okay, so in this integration, it's part of my best statements. So yeah, I think it's quite an important part of the integration. So everything links and everything flows nicely and that we understand why the signs and symptoms. We can't say decreased oral intake related to AOCD, CKD, sorry. You can, but um, yeah, it just sometimes doesn't flow that nicely, as we'll see in this case study. Okay, and then, so yeah, the pathophysiology, then your signs and symptoms, and then your nutritional problem, and then your goals and strategies. So on your integration, I would like I like putting everything on you, including your goals and strategies, which is something I never really used to do before I learned this way, this method, um, which was actually taught to us by one of our supervisors. And I think it's nice to have everything on your integration so that you can literally just take this page, go to your best statement page, and write everything there because it becomes this is literally your blueprint. This is a blueprint for the integration, but then it becomes your blueprint for your best statements, if that makes sense. Okay, so let's get into this. So this is your, yeah, what you're going to use for all of your integrations, basically, your outlay. So it looks a bit messy because there's a lot of things going on here, but let's get into it. So for our patient, he had a smoking history. Okay, he had a poor diet, he was obese class 1, and he had an alcohol intake. Before I continue, you notice that I color coordinated everything, so all of the contributors towards the disease or pre-existing disease, and then the disease that he was admitted with, um, and then the pathophysiology is in purple, and the signs and symptoms in pink, etc. Okay, so all of these things were the contributors towards the hypertension. And then I've also just included the medications just for completeness so we understand what's happening and what's going on. Because, say, for example, he had lupus as well. And with lupus, they use corticosteroids, and we know the side effects of corticosteroids in terms of inhibiting calcium absorption in the body, etc., etc. So, yeah, just to be clear, it's important to include your medication. We also know meds falls under the clinical component of the assessment. So yeah, that's important. And then okay, all of that contributes towards hypertension. Okay, the hypertension then obviously caused or contributed towards the acute and chronic kidney disease, right? Because we know the kidney is important in maintaining and controlling blood pressure. So the medication that he was given was tetralac, thiaxylate, claxane, and then he was awaiting a blood transfusion. Okay, then, excuse me. Okay, then the acute and chronic disease, kidney dysfunction, sorry, contributes to a number of factors because your kidney is not functioning properly. There is many things that may go wrong. So we need to match the pathophysiology to what our patient is experiencing. So if we look in this block, okay, yes, the patient is at an increased risk for CKD, MBD, so chronic kidney disease, mineral bone disease. But our patient, there's no clear signs of that, so that's why I didn't include it in here. Okay, but yes, it definitely is important. So if we look at, I'm going to start on the left hand side. We have inflammation. We had underlying inflammation because of the hypertension. Okay, so remember, because of hypertension, there's a high rate of blood flow in your blood vessels. It damages the blood vessels over time. And with damage, we obviously our body tries to repair it, and there's some underlying inflammation. There's also underlying inflammation because the patient is obese, so he has excess fat stores. I didn't add in an arrow there. It would have looked a little too messy, but yes, definitely contributes towards the underlying inflammation. But now there is, I want to say, inflammation that we notice immediately because of the CRP being high. It's 40, right? So the normal level is 10, it's 40, it's 4 times greater than the normal level. And that's because of the kidney dysfunction. Okay, so we have inflammation. And inflammation also causes an increase in oxidation and reactive oxygen species. Okay, so this we see in a high CRP, and the patient also has a smoking history. Okay, so there's also been oxidation because the patient has been smoking, etc. So we have all of those toxins there and oxidation. With the inflammation, so we have a little E on top of inflammation. It's the etiology, right? So inflammation also increases the metabolic rate inside the body. Okay, so say the inflammation was 8 or 9, it's not marked. Okay, in his case, yes, 40 is high, but it's not as high as, I mean, some of the cases that you would see in ICU where it's like 100, 150, etc. But it's still high. Okay, so we do have, you can say we do have hypercatabolism, hypermetabolism. Hypercatabolism, increase in breakdown of muscle, hypermetabolism, and increase in energy expenditure. Okay, you can also just um, add in that point there if you'd like to above the hypermetabolism and increasing resting energy expenditure. Yeah, I had limited space, or maybe it was just a little bit poorly mapped out. Continuing, so with the hypercatabolism, we see an increase. So the signs and symptoms would be you are muscle area below the fifth centile, your bloods, the CRP being high, and with you can also add in C, so a low oral intake as well, because it links to your etiology of inflammation as well. Okay, because it would cause a low oral intake. Okay, and then so this and the hypermetabolism obviously would increase your protein and energy requirements. Yes, it is a kidney disease patient. Yes, we do need to monitor the protein intake because it is important, definitely. But our patient has had muscle atrophy. I mean, if you look at the AMA, that's below the fifth centile, okay? And the CRP is high. We need to make sure that the muscle stores does not get depleted, or to prevent further muscle atrophy. Okay, so I've also then indicated or included the goals and strategies like we said previously. So your goals for this one, for the hypercatabolism, your goal is always going to be your recommendation or what is stated in the, for example, the ESPN guidelines or the Kidoki guidelines, or whichever one you do use. So the goals to provide, for example, for the protein, 0.8 to 1 gram per kilogram per day, because he is an acute on chronic kidney dysfunction patient. He's not yet on dialysis or anything like that. So we're doing conservative treatment. So that's why I've used the ESPN guidelines, not the Kidoki guidelines. And then your strategies would be your short-term and long-term strategy. Long-term would always be education, right? Short-term is what you're going to be doing in hospital with regards to the hospital diet, or whether you're going to be providing a snack or a sip drink, supplement, or something like that. Okay, same goes with the goals and strategies for the hypermetabolism, you're going to give your energy range that appears in the recommendation. Always remember just to write your reference from that you've used for your goals, or the interval that you've used. So yeah, that's basically the inflammation part of it. I don't think I've covered this as yet. So yes, with the high oxidation, etc., this is your signs and symptoms, the high CRP, the smoking. The plan is to have increased or adequate antioxidant needs. Okay, in this case, it is important to include your micronutrients always, because it definitely forms part of your best statements and your prescription for your patient. So the goal is to meet the DRI or RDA requirements. Remember, your vitamin C uh, requirements or recommendation for smokers is higher compared to non-smokers, so just be mindful of that. And then including your strategies. So short term, long term again. Then the next one. So with this one, yes, we do have iron deficiency anemia because of the low red blood cell count, etc., etc. Okay, so that's going to be your etiology. Your signs and symptoms is your bloods, the low iron count, hemoglobin, all of that, and then your problem would be increased iron requirements. But with this one, we can't really do anything as dietitians in hospital about this. Yes, you can encourage your patients to consume all of their meals, and they on a renal friendly diet. All of that is in its place. But the doctor might prescribe iron supplements. In his case, he's getting a blood transfusion. So in hospital, you can't do much about this, but you can do something about this before discharge. So you're going to give education on eating iron-rich foods, or how to increase iron absorption inside the body by coupling it with vitamin C, rich foods, things like that there. So it's mainly, this short-term strategy won't really work here. Let's delete that. It's mainly like a long-term thing. You're not going to have a short-term strategy as such. So this best statement I would put at the end of the table, the best statement table, and say I wouldn't be able to do anything about it currently with the hospital diet, but I can do something about it before the patient gets discharged. The next best we look at, yes, the impaired excretion of toxic metabolites, so your urea and creatinine, or you can say uremia, right? So that's the etiology. And the signs and symptoms would be then the decreased appetite, but also I did not add in the biochem, so the high urea and creat. Okay, so that's important to add that in. And then your uh, problem would be also inadequate oral intake. Okay, because uremia decreases or causes anorexia and also irritability, things like that, and the patient was irritable. Okay, so your goal for this one can be something like providing smaller meals or providing snacks with meals. So even if your patient is not going to finish the whole meal at, for example, at lunch, but he's going to get a snack afterwards, then he'll eat some of the lunch and then eat the snack, just to ensure that he has adequate intake of yeah of his macro and micronutrients basically. Okay, and then your strategies again, your short-term strategies in hospital as well as at home, once when he's recovering completely. Okay, and then the next one is the impaired fluid balance. We did note that our patient had bipedal edema and he was oliguric, so a urine output of less than 500 moles. The problem is going to be the altered fluid requirements. Okay, again, for your goal, you're going to use your recommendations stated in the Aspen guidelines or whichever guidelines you use, or Kidoki. And then your strategy. So in hospital, short term is going to be to monitor fluids, long term is your education. Then coming to the last one is the problem, right? So this one I'd link directly to the acute on chronic kidney disease, altered macronutrient requirement, because we know we have, because of the kidney dysfunction, the absorption, excretion of toxic metabolites, etc. All of that is changed now. So we will see a high potassium and phosphate in this patient, as we're seeing. And I mean, we have a low sodium, we have low calcium. So there's all of those imbalances, as well as the GFR, which is then the indicator of kidney disease, which is 16. So the etiology in this case, or the E, is going to be the acute and chronic CKD. Okay, and then your goal is going to be to make sure I put DRI, RDA, but it's basically the guidelines. So you'll see in the Aspen guidelines, or the Kidoki guidelines, they normally give the recommendations for these micronutrients specifically because it's kidney disease. So recommendation guideline, I'm just going to put it as that. So yeah, and then I've also just added in omega-3, on the side. You can add that as one of your best. You can make sure that your patient receives adequate omega-3, either from providing a supplement or encouraging the patient to consume it from the meals or something like that there. But I wouldn't say increased omega-3. I would just say adequate. But yeah, it's something nice to add as well. Okay, but these are your main, I would say, in my opinion, the main best statements that comes out from this case. And then in the next slide, I've simply just transferred everything that was on the integration into the best table, right? So we have that problem, etiology, signs and symptoms, the goals, strategies, and your monitoring and evaluation. So with the monitoring and evaluation, we need to go back and look at the signs and symptoms to see, okay, there was a low sodium, there was bipedal edema. What am I going to monitor and evaluate? So you're going to monitor, obviously, the fluid output, the urine output, right? The bloods, the edema, to see if it was, if it's decreasing, if it's getting worse, what's happening in that regard. Same thing with your next best, the decreased appetite. What's happening with that? Is my patient eating, consuming meals, consuming the supplement that I've provided? All of that. Okay. Also with your best statements, I know they would, or ideally, they would like you to prioritize your best statements in your table. So the most pressing issue you start with, and then you go as, you continue as you go along, right? So the most important to the least important. Okay, so in this case, I put the altered fluid requirements because the patient had bipedal edema. Then I added in the inadequate oral intake. Then I did the protein and energy and the micronutrients. I didn't add in everything because, just this is just to give you an example of how to do the best. But it's everything comes from your integration. That's the main point I want to make, is that if you are sitting at 11 o'clock at night during your clinical block and you are so stressed and you have to now fill in this 20 plus pages of this NCR that you have to submit the next morning, you can do everything on your integration and then literally fill out your best statement table, your prescription table, your education section in the NCR with so much of ease because it gives you so much clarity with what to do and how to go about it. Okay, so that's the main point, is if you have a good integration and it's fully filled out with a lot of detail, you simply don't have to think that much for the next few sections of your NCR because everything is on there. Okay, so I mean, even if your best statement table, say you put now increase protein requirements first and then, I don't know, increase energy and then the micronutrient and then the fluid last, for example. Number it to say, okay, this is my most pressing problem that I want to address, the second most pressing, etc., etc. Numbering it to say, I'm going to put this as number one or two or whatever, just so that your examiner, your supervisor, when they mark it, then they know exactly, okay, this is what she's prioritizing or he's prioritizing, and work from there. Okay, so this is the end of this video. It is a bit rusty. I apologize, but it's my first video. And yeah, thank you so much for watching it. Please like, subscribe, and share the video. And stay tuned for more videos and more tips and tricks. Yeah, I definitely think if you have a good integration, everything else becomes so much easier for your NCR. And it's going to be a lifesaver for your clinical block or therapy block, as some students say, because nobody can think at 11 or 12 o'clock at night after a long day. So, yeah, I really hope that this was helpful. Also, please leave a comment down in the comment section if you'd like any specific videos regarding dietetics, or yeah, how did you find this video helpful? Yeah, let me know. Thank you so much.